The following podcast is part of a certified educational activity titled Leveraging Neoadjuvant and Adjuvant Immunotherapy to Break Through the Outcomes Plateau, Prevent Recurrences, and Improve Curability in Early-Stage Cancers. Access the entire activity and complete the post-test at peerview.com/DVD 860. Downloadable slides and practice aids are also available.
Hello, my name is Dr. Jennifer Wargo. I'm an endowed professor in the Department of Surgical Oncology and Genomic Medicine at the University of Texas, MD Anderson Cancer Center in Houston, Texas. I'd like to welcome you today to this educational activity that's focused on the practice-changing expansion of cancer immunotherapies into early-stage cancers. And joining me in today's program are several outstanding investigators, Patrick Ford, Matthew Golsky, and Ronan Kelly. I'd like each of them to introduce themselves. Patrick?
Hi, my name is Patrick Ford. I'm Director of the Thoracic Oncology Clinical Research Program at Johns Hopkins, and I'm delighted to be with you today to talk about lung cancer.
Thank you. Matthew?
My name is Matt Golsky. I'm a medical oncologist at the Icahn School of Medicine at Mount Sinai, where I focus on genitourinary oncology.
And Ronan?
My name is Ronan Kelly. I'm the Director of Oncology at the Charles A. Sammons Cancer Center at Baylor University Medical Center in Dallas, Texas, and my main interests are in esophageal and gastric cancer.
Thank you all. Welcome to everyone, and thank you for taking part in this exciting discussion. So let's go ahead and get started. And so in the next hour or so, we have a couple items on the agenda. First, we're going to start by recognizing gaps and opportunities for improvement in this space. We'll then talk about some foundational concepts. We'll do a pan-tumor exploration of key practice-changing data to update everyone, talk about some cases and practicalities, and finally we'll do a final synthesis and conclusions to the activities. And so by way of introduction, we've made major advances in cancer treatment with the use of immunotherapy and other approaches. And you can see that immunotherapy has finally made the pillars of cancer care. And we know now that this has translated into a reduction in overall mortality, but what I would argue is that there's still a critical need to improve responses to cancer therapy and to limit toxicity in patients with established cancer, as well as opportunities to prevent cancer altogether. And so what we'd like to do first is recognize some gaps and opportunities for improvement in early stage cancers, and this includes in improvements in outcomes for patients with resectable early stage cancers. And why is this? Well, we know that this is actually plateaued, and though surgery remains the single most effective treatment modality contributing to cure in these patients with operable cancers, many patients with early stage cancers still have a very high risk of recurrence with a poor prognosis even after surgery. In addition, removing the tumor in its entirety with no residual cells remaining is challenging because micrometastases are often present, and other multimodality therapies are recommended in addition to surgery in certain tumor types and settings, including chemo in the neoadjuvant setting, but outcomes are still less than optimal. Finally, the accelerated transitions of immunotherapies from advanced to early stage offers new hope of improved outcomes, including reduced risk of recurrence and improved cure rates. And I wanted to talk to each of our experts and have them really give a few thoughts about these concepts.
Sure. Well, for lung cancer specifically, we've seen very few developments in about 15 years since the first data suggesting that perioperative chemotherapy was beneficial. However, in the last couple of years, with initially targeted therapy for EGFR, and now this year, 2 major trials of perioperative immunotherapy, we're starting to see benefits from a PD-1 blockade and potential combinations with chemotherapy. So I think it's an exciting time, and we'll discuss some of those data today.
Great. Matt?
It's a similar story in bladder cancer. Neoadjuvant chemotherapy has been standard for a few decades now, but a large subset of our patients can get cisplatin-based chemotherapy, and the risk of metastatic recurrence after cystectomy is about 50%. So there was a large gap to fill, and immune checkpoint blockade is starting to fill that gap. In kidney cancer, it's been decades of studies with perioperative therapies, one after another not showing benefit, and we finally have adjuvant therapy that shows improved outcomes.
Great. And Ronan?
You know, in esophageal G-junction cancers, we've been watching on enviously, we're all your tumor types with all those advances year after year with targeted agents and immunotherapy advances. And we haven't seen them, but 2021 has been a transformative year for gastric esophageal cancers. We've seen numerous FDA approvals. It's all revolved around the immune system. And of course, we had the approval in the adjuvant space, which was really exciting for us and paradigm changing, absolutely.
Great. Thanks all. So I'm a melanoma surgeon and treat a lot of patients, and what I can tell you is that treatment with immunotherapy and other approaches are being used in patients with earlier stage melanoma. This is data from adjuvant trials showing that these agents are actually effective in really reducing the risk of relapse in these patients, both with either adjuvant targeted therapy or with adjuvant checkpoint blockade. But in addition to this, there's a very strong rationale to use these in the neoadjuvant or pre-surgical setting. And why is that? Well, clinically, we know that though upfront surgery is currently the standard of care in these patients, if you treat patients like this with upfront surgery, up to 70% of patients could actually relapse and die of disease, at least before we started using adjuvant immune checkpoint blockade. In addition to this, there's very strong preclinical data suggesting that treatment with neoadjuvant immune checkpoint blockade is superior to treatment with adjuvant checkpoint blockade with regard to long-term outcomes in these preclinical models. And the benefits of immunotherapies are now expanding to early stage cancer settings with current approvals and indications, with lots of exciting progress being made, especially in 2021. This includes the use of nivolumab across multiple different cancer types, ipilimumab, pembrolizumab, and atezolizumab as well. And so despite the efficacy of adjuvant treatment, there really are potential advantages to using neoadjuvant treatment. And I show a figure here from Caroline Robert's publication in Nature Medicine just a few years ago, where this really highlights this. And you can see that in patients who were treated who have local regional metastatic melanoma, at least, often these patients will have distant microscopic metastases. And if you treat them with upfront surgery and adjuvant immunotherapy, perhaps you don't necessarily get all of these micrometastases and you can get relapse. However, if you treat with neoadjuvant immunotherapy, you treat not only the primary tumor bed or the actual metastatic deposit that's clinically apparent, but you can also treat that micrometastatic disease using immune activation and eliminate all disease. And that's really the hypothesis behind these types of approaches. And in melanoma, investigators worldwide have really banded together to improve patient outcomes through several approaches. There's an international neoadjuvant melanoma consortia that's put out several white papers, not only looking at pathologic responses, but also kind of blueprints for what is the most appropriate neoadjuvant therapy in melanoma. We've also worked with members of the FDA to pave the way for approval, and had a recent publication from Nature Medicine showing real effectiveness of neoadjuvant targeted therapy as well as immune checkpoint blockade, as well as biomarkers to really determine who might benefit the most. But a lot of questions remain regarding surrogate endpoints of both neoadjuvant as well as adjuvant immunotherapy. Certainly overall survival is the gold standard outcome for phase 3 trials, but this isn't really realistic in light of these clinical trials in resectable cancers that makes this research really daunting and expensive. And strategies to expedite clinical trials, including assessing immunotherapies in early stage settings, is the use of newer innovative surrogate measurements. And many adjuvant approvals have been based on disease-free survival, and for neoadjuvant trials, overall survival and event-free survival represent long-term clinical benefit endpoints. But this setting also provides the ability to assess pathologic response as an early surrogate marker. And we'll talk a little bit more about this in each of the cancer types. And so we'll go ahead and move on from here. And so what I wanted to do was provide a little bit of a framework with regard to melanoma. This is, again, 15 years ago, we really didn't have many effective therapies, but we've come a long way. And I've actually, I'd proudly like to say, led the field a bit with regard to some of these neoadjuvant approaches, though now we have seen major advances across cancer types. And with regard to the approved drugs for the adjuvant therapy of stage 3 melanoma, in the old era, pre-2009, we really only had high-dose interferon. And this was not horribly effective and was pretty toxic. However, over the last decade or more, we've now had FDA approval of several agents in the adjuvant setting, including ipilimumab, nivolumab, dabrafenib and trametinib, and also pembrolizumab. And we'll talk a little bit about this data. And so this is the EORTC 18071 trial, which was the ipilimumab versus placebo, where they saw a reduction in risk of relapse. However, the problem with this was there was a tremendous toxicity in these studies, and 54% actually had to discontinue treatment. Now, how about if you compare adjuvant nivolumab versus ipilimumab, and this was the Checkmate 238 study, where they took patients with stage 3B or 3C versus stage 4 M1A or M1B versus M1C melanoma, and stratified them by tumor PD-L1 status at a 5% cutoff. And what they found really after looking at this was that there was a benefit of treating with the nivolumab versus ipilimumab, and this really set the new standard for treatment with patients, particularly in light of lower toxicity. Following that, there was another study of pembrolizumab versus placebo after complete resection of high-risk stage 3 melanoma, and this was the EORTC 1325 or Keynote 054 study, where they took high-risk resected stage 3 cutaneous melanoma patients and randomized them 1-to-1 to either pembrolizumab versus placebo as adjuvant therapy for a total of 18 doses. Looked at recurrence, and these patients were able to cross over. And what they found when they did these studies is that there was a statistically significant benefit to treatment with pembrolizumab over placebo. And this data was presented by Lex Egermont and really made a huge splash, again, suggesting that adjuvant use of pembrolizumab following resection of high-risk resected melanoma is a tractable strategy. Now, how about the final DMFS analysis? And again, this final analysis, again, really supports this. Now, how about the use of adjuvant nivolumab and ipilimumab versus nivolumab in stage 3B, C, and stage 4 melanoma patients? And this was the Checkmate 915 study, where the primary endpoint was relapse-free survival in PD-L1 negative patients. There was an intention to treat population analysis, and really the bottom line is this study did not meet its primary endpoints. There was no benefit. But when they looked at a subset of really high-risk patients who had resected stage 4 disease, they found that there was some benefit, and so perhaps some of these patients benefit. But the take-home message is that that combined treatment with ipi-nivo in the adjuvant setting was no better than nivolumab alone, at least for the majority of patients. So what's next? Well, certainly adjuvant therapy in high-risk patients with stage 1 or 2A only, is certainly being done at this point, and also neoadjuvant immunotherapy developments will be discussed. And so stage 2A and stage 2B or C, these patients have a real risk for relapse, and sometimes even higher than stage 3A. And if you look at the survival for these patients, the question is, will these patients actually benefit from treatment with immune checkpoint blockade? And so there are ongoing trials of adjuvant anti-PD-1 antibodies for patients with stage 2B and C melanoma. There's the Keynote 716 trial as well as the Checkmate 76K. Both of these are looking at randomization of treatment with anti-PD-1 versus placebo, and looking at rates of relapse in these patients. In addition to this, there's a nivo-mela adjuvant treatment of high-risk stage 2 melanoma, and in this, patients are actually assessed by the Melagenex test, where they're randomized if they have a high score to either have treatment with nivolumab in the adjuvant setting versus observation, and if they have a low risk score, they're just treated with observation. But what's the next revolution? And that's certainly neoadjuvant immunotherapy, and that's neoadjuvant anti-PD-1 versus neoadjuvant anti-PD-1 in combination with anti-CTLA-4. And really the first studies that were done in the neoadjuvant setting in patients with resectable high-risk local regional melanoma metastases were done in the setting of treatment with neoadjuvant BRAF and MEK inhibitors. And this was a cohort of patients who were treated with either upfront standard of care surgery versus treatment with neoadjuvant and adjuvant BRAF and MEK inhibitors. And this was a study that was done at MD Anderson Cancer Center. And what we found when we did this study is that patients who were treated with neoadjuvant and adjuvant BRAF and MEK inhibitors had survival and relapse-free survival benefit over those treated with standard of care upfront surgery, which intuitively makes sense. But what was really striking was that it was only those patients who achieved a pathologic complete response to therapy who actually derived any benefit, whereas if patients failed to achieve a pathologic complete response, they really had pretty poor outcomes. Now, others have actually recapitulated these findings. This is data from Georgina Long that was published, which again showed that if patients achieve a pathologic complete response in the setting of treatment with neoadjuvant BRAF and MEK inhibitors, they do much better than if they fail to achieve a path CR. Now, how about neoadjuvant immune checkpoint blockade? So we and others have now run studies using treatment with either neoadjuvant anti-PD-1 versus neoadjuvant anti-PD-1 plus anti-CTLA-4, followed by adjuvant PD-1, and this was a trial that we ran at MD Anderson Cancer Center, where we randomized patients to either undergo treatment with ipilimumab 3 mg per kg and nivolumab 1 mg per kg versus nivolumab at 3 mg per kg for a total of 9 weeks of therapy, restaged them, did a surgical resection, and then put them onto adjuvant anti-PD-1 therapy. And what we found when we ran these studies is that if patients received combined immune checkpoint blockade targeting CTLA-4 and PD-1, they actually were 3 times as likely to have a radiographic response and nearly twice as likely to have a pathologic complete response. However, that came at a large cost. So they actually had a much higher rate of grade 3 or above adverse events, 73% versus 8% in the PD-1 monotherapy arm. And other groups have recapitulated these findings. So there's a group from Penn that actually gave a single dose of pembrolizumab to patients with a high-risk resectable local regional metastatic melanoma and showed that after a single dose of pembrolizumab, 30% of patients had a major pathologic response, and if they did, they actually had long-term benefit. So this really galvanizes this approach. And importantly, others have done studies where they looked at neoadjuvant versus adjuvant ipilimumab and nivolumab in the setting of treatment with high-risk resectable local regional metastatic melanoma, and saw importantly that in the setting of neoadjuvant treatment, they actually saw an expansion of T-cell clones in these patients. Now, how about can we optimize the dose and the dosing regimen for these patients? And Christian Blank and others at the Netherlands Cancer Institute have done just that. They ran this OPUS and NEO study, which identified the optimal treatment scheme. So what they did in this study is took patients with high-risk resectable metastatic melanoma, randomized them to one of 3 arms where they either got IPI-3-NIVO-1 for 2 doses, IPI-1-NIVO-3 for 2 doses, or they got sequential ipilimumab and nivolumab treatment. Patients then underwent surgery and were followed, and what they found is that the optimal regimen was really this IPI-1-NIVO-3 regimen, where they had a very high pathologic response, 77%, with a relatively low rate of grade 3 or above adverse events at 20%. Actually found, as we did, that the other regimen, or IPI-3-NIVO-1, was associated with high rates of response, but also with high toxicity. And the sequential really had less efficacy with much higher toxicity. And the relapse-free survival after 2 years of follow-up and pathologic response really predicts outcome. And so you see that patients who are treated on this trial actually did quite well. Really only 1 patient with a pathologic response has relapsed. And you can see that if patients have a pathologic response to treatment with neoadjuvant combined immune checkpoint blockade, they do quite well, whereas if they fail to achieve a path CR, they don't. Now, how about if we contrast this with targeted therapy? And this is data from a pooled analysis by the International Neoadjuvant Melanoma Consortia, which compared treatment with neoadjuvant immunotherapy versus treatment with neoadjuvant targeted therapy. And what they found is that if you treat patients with neoadjuvant immunotherapy, if they have any type of response whatsoever, they actually derive long-term benefit. And it's only those patients who fail to achieve any response that actually have very poor outcomes. Now contrast that with treatment with neoadjuvant targeted therapy, and you can see with regard to targeted therapy, it's only those patients who have an pathologic complete response with zero viable tumor that actually derive any benefit. And some of those patients will actually relapse. And if they have anything less than a complete response, really very few of those patients derive any benefit whatsoever. Now we're trying to iterate on this and go even further. This is the so-called PRADO study, where we're actually able to eliminate therapeutic lymph node dissections in good responders with neoadjuvant combined immune checkpoint blockade. And so what we've done in this study is take patients with stage 3B or 3C melanoma and give them 2 courses of treatment with ipilimumab at 1 mg per kg and nivolumab at 3 mg per kg, then resect just that index node, and if they've had a pathologic complete response or a major path response with less than 10% viable tumor, we don't do a completion lymph node dissection and just follow those patients. If they have a partial response, they get a completion lymph node dissection and are followed. And if they don't have a pathologic response, they undergo the complete lymph node dissection and are also started on adjuvant therapy with nivolumab. And really what's come out of this is that PRADO has actually confirmed the high pathologic response rate and safety that was observed in the previous OPUS and NEO arm B at that IPI-1 Nivo 3 dose. And the pathologic complete response rate was actually 71% with a very low rate of grade 3 or above adverse events, only 22%, which is actually pretty good. And importantly, therapeutic lymph node dissection was actually omitted in 60% of patients, which is a real paradigm shift. And so with regard to expert insights for melanoma, I think neoadjuvant treatment with immune checkpoint blockade in patients with high-risk resectable metastatic melanoma is generally safe, but optimal regimens remain incompletely defined, though I think we have some insights on this. Additional strategies should be considered in patients with immunologically cold tumors such as acral and mucosal melanomas, but overall the neoadjuvant approach is quite promising. Now just to, I know really we're mainly talking about melanoma, GI cancers, GU cancers, and lung cancer, but also wanted to share some really important data that was recently reported in triple-negative breast cancer, where we now know from the Keynote 522 study for pembrolizumab for early triple-negative breast cancer that the FDA approved pembrolizumab for high-risk early-stage triple-negative in combination with chemotherapy as neoadjuvant treatment and has continued as a single agent as adjuvant treatment after surgery. And this is really important data that was recently reported and has now translated into an FDA approval. And so with that, I'll turn it over to Dr. Ronan Kelly, who will discuss upper GI cancers.
Thank you very much. And now we'll move to esophageal and gastroesophageal junction cancers. And who would have thought that this would be the second FDA approval in an adjuvant space after melanoma? I don't think many people would have suggested that esophageal would be coming out ahead of lung or bladder or kidney, which obviously have all seen subsequent approvals. But I think we wouldn't have thought in 2021 esophageal would be the second adjuvant FDA-approved indication for a checkpoint inhibitor. But the problem we've had with esophageal and GE junction cancer, of course, is patients are very frail. It's probably one of the largest oncologic operations you can do to a patient in terms of removing their esophagus. That has obviously significant impact for calorific intake, weight loss, having to get used to a whole new GI system and so on. So that's why we've had really limited data on what to do in the adjuvant setting. We know that more chemotherapy, if you've got chemoradiation before surgery, hasn't really been able to improve patient outcomes dramatically. So we wanted to check adjuvant immunotherapy as we'd seen some advances in the metastatic setting. And so this study took a long time. Probably because adjuvant indications and studies are a bit more challenging to run, but also, as I mentioned, an esophagectomy is a large operation to recover from. But thankfully, we persisted and we did manage to enroll 794 patients in a 2-to-1 manner. This was done over 27 countries, so it was probably the first global study in a prospective phase 3 manner that we've done. Previously, all of our practice-changing trials in upper GI malignancies have come from single country studies. Here now we had 27 countries participating. And the entry criteria you can see on the left, any patient with stage 2 or 3 esophageal or GE junction cancer, we didn't mind if it was adenocarcinoma or squamous cell carcinoma, but they all had to get neoadjuvant chemoradiotherapy followed by surgery, and the surgery had to be an R0 resection. And then once the patients had recovered, if they didn't have a pathologic complete response, so anyone who has residual pathologic disease greater than YPT1 or YPN1, and that makes up the majority of patients with esophageal cancer at 75 to 80%. So only about 20% to 25% have a PAC-CR following chemoradiation. We don't know what the difference is between their biology and others. That's the same in many tumors. Why do some people have a great response to our historical treatments and others not? But so we basically said, okay, anyone with good biology, we won't put you on this study. We'll just put you on if you haven't achieved a PAC-CR. And then the randomization was 2-to-1, and patients either got placebo, which was the current standard of care with close observation, because now you've already had chemo, radiation, and surgery, so-called trimodality therapy. And the current standard was close observation. Or we said, okay, well, we'll do nivolumab every 2 weeks for the first 4 months. And then for the remaining year, 480 milligrams, slightly higher dose once a month. And it's pretty normal, I think, across tumor types for these adjuvant studies to be 1 year of a checkpoint inhibitor. And so we published our findings in the New England Journal of Medicine on April the 1st of this year. And here was some of the data that we showed. The median age of patients was in the low 60s. You can see here, in the interest of time, I'll just set that it was predominantly 60% esophageal cancer, 40% gastroesophageal junction cancer. And the histology, we see much more adenocarcinoma in the United States, although squamous cell is probably the biggest histology globally for esophageal cancer. And then you can see the pathologic lymph node status, tumor cell, PD-L1, unlike lung, tumor cell PD-L1 is probably not the best way to do this for GI malignancies. We have something called the combined positive score, the CPS score, which is basically a combination of tumor cell staining, but also then all of the immune cells that are nearby the tumor. And then you can see here some of the pathologic entry requirements and the lymph node status, as well as the tumor stages of patients. So this was the take-home message. We showed a doubling in the median disease-free survival from 11 months to 22.4 months. And that was the original data set where you see it's 24.4 months of follow-up. That was in the New England Journal manuscript. Many people may not have seen, however, just a few weeks ago at ESMO, we presented an additional 8 months of follow-up. And I think you can see all of the hazard ratios as I go through the next couple of slides are actually improving with additional follow-up, which is really quite reassuring. We are, of course, waiting for overall survival. As Jennifer mentioned, we have to wait for that. But what I'll show you is other efficacy endpoints that I think are hopefully very promising that we may see an overall survival benefit. But even this, if you look at this placebo curve, remember, these are patients who had trimodality therapy and their disease is recurring in 11 months. That is unbelievable to me. And it shows, I think, that we can't just observe these high-risk patients anymore. We have to give them an additional option to see if we can prevent disease from returning. As I mentioned, as we wait for overall survival, some of the other efficacy endpoints we've seen are distant metastasis-free survival. So again, that time for the first distant metastasis to present. And you can see again in the original data set on the right, the hazard ratio was 0.74, but now with an additional 8 months, we've now directionally improved the hazard ratio. We're now down to 0.71. You could see it's over a year now in terms of distant metastasis-free survival from 16.6 months to 29.4 months. So really, this is the first advance we've ever seen in the adjuvant setting in esophageal or GE junction cancers. We've never had any indication that could show an improvement post the standard treatments. And then the last thing I'll show here is progression-free survival too. Again, are we impacting the immune microenvironment to make subsequent treatments hopefully work better? Again, it's preliminary data. We don't have a median to report for the nivolumab. We have in in placebo 32.1 months, hazard ratio there 0.77. So again, all of those efficacy endpoints of disease-free survival, distant metastasis-free survival, progression-free survival 2, all favoring adjuvant nivolumab. If we look at the response based on histology, I think we've seen this in other tumor types. I think squamous cell, for whatever reason, and we could get into that, looks like it's responding better to the checkpoint inhibitors here. You can see in the different colors, the squamous cell indication was almost 3 times from the placebo, 11 months to 29.7 months. But we were very excited to see adenocarcinoma, which, as I mentioned, is predominant histology in the United States, also significantly improving, 11.1 months to 19.4 months. And then in the interest of time, I'll just quickly mention that nivolumab seemed to favor all of these subgroups regardless. So we saw responses. You can quickly see everything is on the nivolumab side, from tumor location to histology. And if we continue on that theme, you can see also a CPS score does seem to impact. We know in esophageal gastric cancer, the combined positive score is important. We need to learn a little bit more about this. It'll be interesting to talk with my colleagues about adjuvant settings. Are we changing PD-L1 as a result of what we've given before we assess on the tumor what the CPS score is? Is that really an adaptive resistance of PD-L1, or is it as a result of giving radiation in this case, which we know causes interferon gamma release and PD-L1 to go up? So I think as we look at early stage tumors, we need to understand more about CPS and PD-L1 score. And is it the real same as what we're looking at in the metastatic setting? So the FDA approved this combination on May the 20th, the first FDA approval ever in upper GI tumors in early stage malignancy. So that's very exciting for us. And it gives our patients now hopefully an opportunity to really prevent disease from occurring. And like in every other tumor, of course, now we see a whole plethora of trials, different combinations, different strategies in the neoadjuvant setting, in the adjuvant setting, giving with chemo alone versus chemoradiation. And so we'll see how this pans out over the next couple of years. So, as I mentioned, a couple of things there. I think the key things for me are, what's the immune microenvironment difference in early stage tumors versus late stage? Can we just automatically assume we can take what we know in metastatic and transplant it into early stage? I don't think so. I think also my colleagues here are talking about very sensitive tumors like melanoma, lung, bladder, and kidney. We'll have to see if a neoadjuvant strategy is the right strategy in a tumor like esophageal GE junction, or do you need the tumor out and then be dealing with a minimal residual disease status? And so that'll be interesting to see across these other tumors that aren't as hot as melanoma and lung, for example. And where does ctDNA play a role in this? Does every patient get this strategy, or do we need to define subgroups who will benefit? And I think circulating tumor DNA may have a role in that regard. So thank you very much. And I will hand it over to the next speaker.
Thank you, Ronan. That was fantastic. And so our next speaker is Dr. Matt Golsky, who will speak to us on urologic malignancies and neoadjuvant therapy.
So immune checkpoint blockade has had a dramatic role in the treatment of patients with urothelial cancer. And once activity was shown in the advanced disease setting, these drugs were moved rapidly into earlier disease states. And I think that bladder cancer has the designation of actually having the earliest approval in terms of a clinical disease state for immune checkpoint blockade, and that's for non-muscle invasive bladder cancer. This is carcinoma in situ, a non-invasive cancer where immune checkpoint blockade has been studied. So in Keynote 57, patients with non-muscle invasive bladder cancer, that is carcinoma in situ, that had recurred despite prior BCG treatment, another immunotherapy, that had recurred despite that treatment were enrolled on a single-arm study with pembrolizumab. And because carcinoma in situ is sort of carpets the urothelial lining, it can't be completely resected, and so response rate is actually an appropriate endpoint. After giving the treatment, a urologist looks in the bladder again to see if there's evidence of persistent disease or that carcinoma in situ has cleared. And so complete response is an endpoint on these studies. And you can see in Keynote 57 that of the 96 patients enrolled, 39 achieved a complete response, and that was at 3 months. And so the complete response rate was fairly impressive. And then the durability of the response, of course, is what's important here, because previously, the standard treatment for patients with BCG-unresponsive carcinoma in situ has really been cystectomy. There are other intravesical treatments that can be applied, but really the gold standard is cystectomy. And so achieving a complete response and having that durable that defers or potentially avoids cystectomy is really the goal here. And you can see that of the 39 patients who achieved a complete response, about half of those responses had some durability. 19% of this entire cohort had a complete response that lasted greater than a year. And 19% is around in the ballpark range of the response rates that we see with immune checkpoint blockade in more advanced disease settings. It's around 20 to 30%. So I think that's pretty consistent. So this led to the approval of pembrolizumab for the treatment of patients with BCG-unresponsive carcinoma in situ. There was a second study that looked at a very similar disease population, that's SWOG 1605. In SWOG 1605, while the eligibility was quite similar, the endpoint was a little bit different. It was a 6-month CR endpoint, and this required biopsy confirmation. And so the study was closed a little bit early, but if you line up the results side by side, it looks like atezolizumab is achieving pretty similar results to what we see with pembrolizumab in this setting. In muscle-invasive bladder cancer, the standard treatment is cystectomy, surgical removal of the bladder, or radiation can sometimes be used for primary treatment. When cystectomy is used, neoadjuvant cisplatin-based chemotherapy is standard, but we know that a large subset of our patients with bladder cancer cannot receive cisplatin-based chemotherapy because of comorbidities. So we have a couple of sets of patients who are at high risk despite neoadjuvant chemotherapy and surgery, or surgery alone. And that's really defined based on the pathological extent of disease after cystectomy. Because we know that patients are at high risk for recurrence despite those prior therapies, there's been a need for adjuvant therapies in this state, and other chemotherapy, switching to different chemotherapy, which we don't have a lot of non-cross resistant chemotherapy drugs historically in bladder cancer. Switching to different chemotherapy after surgery in retrospective analyses has really shown mixed results. So this was a major unmet need, and 3 randomized trials were launched to determine whether or not immune checkpoint blockade has a role here. IMvigor10, Checkmate 274 in the Ambassador study. The first 2 studies have read out, and I'll discuss. The Ambassador study closed to enrollment recently, and we don't have the results yet. All of these studies use almost identical eligibility criteria, but there are a few clinical trial design nuances here which might indeed be important. IMvigor10 had an observation arm as the control arm, while Checkmate 274 had a placebo arm as the control arm, and potentially that makes a difference in terms of interpretability. So here's the results of IMvigor10. Disease-free survival was the primary endpoint, and you see unfortunately no difference with atezolizumab versus observation in this study. Interestingly, though, in a really elegant analysis published by Tom Powles and colleagues in Nature, looking at ctDNA using the Signatera platform in a retrospective fashion, patients who had detectable ctDNA on cycle 1, day 1 of treatment on this study treated with atezolizumab had a disease-free survival and overall survival benefit compared to observation, whereas patients with ctDNA negative assays on cycle 1, day 1 did not. And so retrospective analysis, but very intriguing in the context of a large randomized study, and certainly is hypothesis generating for confirmation in prospective studies which are ongoing. CheckMate 274 showed somewhat different results. So remember, this randomized patients to nivolumab versus placebo. These are patients who had neoadjuvant chemotherapy, then cystectomy, and had, or an FRU-ureterectomy, and had pathologic T2 or higher disease, or patients who were cisplatin ineligible and at surgery had pathologic T3 or higher disease. The primary endpoint for CheckMate 274 was a co-primary endpoint of disease-free survival in the all-comer population and disease-free survival in the subset of patients with high PD-L1 expression. For the purposes of this study, PD-L1 was assessed using the 28-8 antibody clone, and this is tumor staining at a level of greater than or equal to 1%. You see the results here in the intent to treat population. Adjuvant nivolumab was associated with a disease-free survival benefit with a hazard ratio of 0.7, and in the patients with tumors harboring high levels of PD-L1 expression, a hazard ratio of 0.53. Here's the adverse event profile with adjuvant nivolumab versus placebo, and there were no signals of different toxicities compared to what we've seen in the advanced setting in urothelial cancer or other disease settings. So on the basis of that study, in August of 2021, the FDA approved nivolumab as adjuvant treatment for patients with muscle-invasive urothelial cancer at high risk for recurrence after definitive surgical resection. Of course, as I mentioned, neoadjuvant therapy has really been the standard for the treatment of patients with muscle-invasive bladder cancer, and this is neoadjuvant cisplatin-based chemotherapy. In patients for whom cisplatin-based chemotherapy can be applied, of course, there's the interest in determining whether or not we can combine this treatment with immune checkpoint blockade. And for patients who cannot receive neoadjuvant cisplatin-based chemotherapy because of comorbidities, that's been a major unmet need in the neoadjuvant setting, and immune checkpoint inhibitors have moved rapidly into that space. And you can see here the results of two large single-arm studies of single-agent immune checkpoint blockade in patients with muscle-invasive bladder cancer, one administering 3 cycles of pembro, the other administering just 2 cycles of atezolizumab. And you see pathological complete response rates here of 30 to 40%, and that's really comparable to what we see with cisplatin-based chemotherapy. So neoadjuvant immune checkpoint blockade, certainly intriguing in this disease. Combinations with cisplatin-based chemotherapy also showing compelling results in single-arm phase 2 studies. And as a result of all of these early studies, a number of large international randomized studies, either enrolling patients who are cisplatin eligible to cisplatin-based chemotherapy plus immune checkpoint blockade versus standard of care neoadjuvant cisplatin-based chemotherapy, or for patients who are cisplatin ineligible, either single agent immune checkpoint blockade or immune checkpoint blockade based combination studies. Some of these neoadjuvant studies are just closing to accrual, and so the results we'll see in the upcoming years. I'm going to switch gears to kidney cancer, where of course immune checkpoint blockade has had a major role in the metastatic setting. First-line standard treatment, either with ipilimumab plus nivolumab or immune checkpoint blockade-based combinations with VEGF receptor tyrosine kinase inhibitors. It's been really difficult to demonstrate a benefit with perioperative systemic therapy in renal cancer. Decades of studies with cytokines first and then VEGF receptor tyrosine kinase inhibitors really hadn't shown a compelling benefit for perioperative systemic therapy. And immune checkpoint blockade is just now starting to change that. So here you see the design of a number of different studies seeking to integrate immune checkpoint blockade as perioperative therapy for renal cell cancer. And one of these studies, the PROSPER study, as you can see on the slide, integrates a brief neoadjuvant period, but the rest of these are adjuvant studies. One of the reasons for this is that in kidney cancer, the patient journey includes diagnosing an abnormality on imaging typically, and then to the operating room for surgery without that biopsy up front historically, and that has made neoadjuvant strategies somewhat more difficult to integrate into the treatment of renal cell cancer. So here's the results from Keynote 564. Keynote 564 enrolled patients with renal cell cancer post-nephrectomy who had stage 2 high-risk disease, stage 3 disease, or stage 4 NED, and randomized patients to receive pembrolizumab versus placebo. Here you can see the disease-free survival benefit with a hazard ratio of 0.68, an early look at survival also showing a promising signal. And so just in the past week, November 17th, the FDA approved pembrolizumab as adjuvant treatment for patients with renal cell cancer, and this will certainly change the way that we treat this disease. Here's the design of Checkmate 914, which is assessing whether or not we should give doublet immune checkpoint blockade with CTLA-4 blockade plus PD-1 blockade versus PD-1 blockade alone. And here's the design of the PROSPER study. As mentioned, one of the studies seeking to determine whether or not a brief period of neoadjuvant immune checkpoint blockade has a role in the treatment of patients with high-risk renal cell cancer. A number of studies are seeking now to integrate the strategies into the perioperative setting that have really changed the way that we treat patients with metastatic disease, which are combinations of immune checkpoint inhibitors plus VEGF receptor tyrosine kinase inhibitors. Of course, treatment with VEGF receptor tyrosine kinase inhibitors has a role for the treatment of kidney cancer based on the pathogenesis of the disease, but these multi-targeted kinase inhibitors, of course, also inhibit other kinases that might be relevant in making the immune microenvironment more permissive for a response to immune checkpoint blockade, including inhibition of the TAM kinases. As shown, immune checkpoint blockade is now standard treatment in the adjuvant setting for urothelial cancer and for kidney cancer, something that we could not say just a year ago. And like we've heard from the other speakers, the major questions now are going to be whether or not we move all of these treatments to the neoadjuvant setting, for which there's an immunological rationale, but at the same time, that means treating patients with multiple therapies instead of potentially using a risk-adapted strategy and allowing information based on pathological stage to help guide patients at highest risk. So those are some trade-offs that I think we're going to have to keep in mind as we see these neoadjuvant studies read out. Thank you for your attention.
Thank you, Matt. That was really outstanding. And so for our next speaker, we'll have Dr. Patrick Ford, who will discuss neoadjuvant and adjuvant therapy for non-small cell lung cancer.
Thank you very much, Jennifer. So now I'm going to discuss some new developments in lung cancer. So we've seen a lot of, over the last 10 years, really, immunotherapy has come to the fore for advanced lung cancer. You'll see moving from the top of the screen here to the bottom. Initially, we had approvals in pre-treated non-small cell lung cancer after prior chemotherapy. Then moving to the first line setting, we now have multiple different regimens approved, including chemo plus single agent PD-1 blockade, chemo plus doublet immune checkpoint, and immune checkpoint alone for PD-L1 high disease. In stage 3 disease, unresectable, so we're gradually getting to earlier stages here, durvalumab has become the standard therapy after definitive chemoradiation. And now we're starting to see developments in the neoadjuvant and adjuvant setting with 2 positive phase 3 trials reported this year. Back in 2018, we reported a small pilot study of 21 patients who received 2 doses of neoadjuvant nivolumab prior to surgery for stage 1B to 3A non-small cell lung cancer. This was intended to be mainly a translational science focused study. However, we were surprised to see that 9 out of the 20 patients who had resections actually had major pathological responses, and this was defined as 10% or less residual viable tumor at the time of resection. This also included 2 patients who had pathological complete responses, which is quite remarkable considering this is 2 doses of therapy over just 4 weeks prior to surgery. And these responses appeared to occur irrespective of PD-L1 status. My colleague, Dr. Provencio in Spain, conducted the NADIM study. This was a phase 2 study enrolling patients with more locally advanced disease, stage 3A. This disease is at the cusp of being unresectable. And this was a relatively locally advanced disease with more than half of the patients having a multi-station mediastinal nodal involvement. And the findings here were also very promising, with more than half of the patients having a pathological complete response. You'll see in blue, in light blue. And you'll also see that the vast majority of these patients at more than 2 years of follow-up have not had a relapse of their disease. And these responses appeared to occur irrespective of PD-L1 status, tumor mutation burden. And also treatment was highly feasible and didn't appear to impact the feasibility of surgery. The CheckMate 816 study was the first phase 3 neoadjuvant chemoimmunotherapy study to be reported in lung cancer. And this enrolled patients with stage 1B to 3A non-small cell lung cancer using the 7th edition. So the stage 1B patients in this trial would currently be in stage 2. Patients had a good performance status, and they were randomized to either the control arm, which was 3 cycles of platinum doublet chemotherapy given prior to surgery, or the investigational arm, which was chemotherapy plus nivolumab. It should be noted the study originally had a third arm of nivolumab plus ipilimumab. However, given developments in metastatic lung cancer where chemoimmunotherapy was coming to the fore, this arm was discontinued early and was not part of the primary analysis. The primary outcome of this study was for primary endpoints of both pathological complete response and also event-free survival. And these are the demographics of the patients enrolled. So you'll see spread across North America, Europe, and Asia, a pretty representative population, high proportion of stage 3A patients, 63%, equal numbers of squamous and non-squamous. And also you'll see about 50% of the patients had PD-L1 positive tumors. And this is something we also see in the EMPIRE-010 study, which I'll discuss shortly. So these were the treatment outcomes and surgical outcomes. So the large majority of patients completed the 3 cycles of therapy, 94% in the Nivo chemo arm, 85% in the chemo arm. More patients in the Nivo chemo arm had lung sparing surgery, and this is an important outcome, especially for more locally advanced lung cancers, as pneumonectomies have increased rates of morbidity and mortality. Similar rates of patients had cancelled definitive surgery, 16% in the Nivo chemo, 21% of patients in the chemo arm. It should be noted, however, most of these cancellations were not actually due to disease progression, but rather in some cases patients choosing alternative therapies such as definitive chemoradiation, or some patients being found to have poor lung function just prior to planned surgery. Delays to surgery were defined as surgery occurring more than 6 weeks after the last dose of chemo or chemoimmunotherapy. And these again were not generally related to toxicity, but largely administrative regarding having a war list time or planning around holidays. And these were the primary outcome for the pathological complete response endpoint. The addition of Nivo to 3 cycles of chemo increased PCR from 2.2% with chemo alone to 24% with chemo plus nivolumab. And this was assessed centrally and is in the entire intention to treat population, and the pathologists were blinded to which arm of the study the patients were on. That when you look specifically at those patients who had a resection, again, very similar results, an improvement from 3.2% with chemo alone to 30.5% with Nivo chemo. And focusing only on the primary tumour, so not looking at the lymph nodes, very similar results as well. In the exploratory arm of Nivo plus Ipi, the PCR rate was 20.4%. And just to talk a little bit about PCR in lung cancer, historically this has been retrospectively strongly associated with other outcomes such as disease-free survival and long-term overall survival. However, this is the first prospective study to use PCR as a primary endpoint. Also looking at a major pathological response, and remember this is 10% or less residual viable tumour in the resected specimen, and again a similar increase from 8.9% with chemo alone to 36.9% with Nivo chemo. And looking at the percent residual viable tumour in the resected specimen, and there was a significant improvement when you added Nivo to chemo. 74% of residual viable tumour in the chemo alone arm went down to just 10% residual viable tumour in the Nivo plus chemo arm. There was a subpopulation, about 1 in 4 patients had available samples for a tumor-informed circulating tumor DNA assay. And this relied on obtaining whole exome sequencing of the primary tumor and then creating a bespoke panel of ctDNA mutations. And again, more patients in the Nevo chemo arm cleared ctDNA between cycle 1 and cycle 3 of neoadjuvant chemo, 56% versus 34% in the chemo arm. And among those patients who did clear ctDNA, those patients who got Nevo plus chemo were more likely to have a pathological complete response. I mentioned earlier that perhaps Nevo chemo counterintuitive in some ways because you're adding a new drug, but more patients had lobectomies or lung-sparing surgery if they got Nevo chemo, and fewer patients required pneumonectomies, particularly those with more locally advanced stage 3A disease. And perhaps this is because of response to therapy. However, we're looking into this a little bit further as well. So in summary, in terms of Checkmate 816, it met the first endpoint of PCR. And just this past week, November 8th, we had a press release stating that event-free survival is also positive in this study, favoring Nevo plus chemo across the population. I think this is the first phase 3 trial of neoadjuvant therapy in lung cancer to demonstrate a statistically significant and clinically meaningful benefit as neoadjuvant therapy for lung cancer. And we'll be looking forward to seeing the full results of this study in the next few months. There are several other phase 3 neoadjuvant chemo plus PD-1 or PD-L1 studies ongoing. You'll note that a couple of these other studies also use PCR as a primary endpoint, or else event-free survival or overall survival. One notable difference between Checkmate 816 and the other studies is that there was no adjuvant systemic therapy mandated in Checkmate 816. So it was 3 cycles of chemoimmunotherapy or chemo prior to surgery, and then no mandated post-operative therapy. Whereas all of the other studies have either 1 year of PD-1-based therapy post-operatively or 1 year of placebo. So moving on to the adjuvant setting, the EMPOWER-010 study was reported at ASCO earlier this year and published in the Lancet journal. This enrolled patients with stage 1B to 3A non-small cell lung cancer. All patients had to commence at least 1 cycle of adjuvant cisplatin-based chemotherapy. Then after completing chemotherapy, were randomized to a control arm with best supportive care, or the investigational arm of the anti-PD-L1 agent atezolizumab, given once every 3 weeks for up to 1 year. There was a relatively complex primary endpoint, so you'll see on the right of your screen. Initially, disease-free survival would be assessed in the PD-L1 1% or greater, stage 2 and 3A population. Remembering this is the 7th edition, so not including those tumors 4 centimeters or greater. If that was positive, then disease-free survival would be assessed in the full stage 2 and 3A population. Moving further down, you'll see if that was positive, disease-free survival would be assessed in the entire intention to treat population. And finally, if all of the disease-free survival endpoints were positive, overall survival would be evaluated. And these are the results. So you'll see on the left of your screen, there was a significant improvement in disease-free survival in the atezolizumab arm in those patients who had PD-L1 positive tumors with a hazard ratio of 0.66. Moving on to the population, irrespective of PD-L1 with stage 2 to 3A disease. Again, a significant hazard ratio, however, not quite as impressive, 0.79. And finally, on the right of your screen, in the entire randomized population intention to treat, stage 1B to 3A, the hazard ratio was not yet significant at 0.81. And this is disease-free survival in the key subgroups of the PD-L1 positive stage 2 and 3A population. And this is the population which is a recently attained FDA approval for atezolizumab. So you'll see most groups do derive benefit. Those patients with specific mutations, perhaps less so. Also those patients who were current smokers. And looking at the stage 2 and 3A population, a disease-free survival by disease and treatment characteristics, again, a benefit for almost all groups. Perhaps a slight suggestion cisplatin gemcitabine might not be as beneficial, but again, these subgroups are relatively small. And looking by the full randomized population of stage 2 and 3A, this is where we see some interesting breakdown. So when you look at PD-L1 high tumors of 50% or greater very clear benefit, a hazard ratio favoring atezolizumab of 0.43. When you look at the PD-L1 negative tumors, almost no benefit, 0.92 hazard ratio. However, when you look at the 1 to 49 group, so remembering that atezolizumab is approved for 1% or greater, there perhaps is some signal of benefit, but not significant, a hazard ratio when you exclude EGFR and ALK of 0.82. So I think this is a very clear benefit for the high PD-L1 patients, less so for those of 49% or less. And again, as I mentioned, atezolizumab now approved, our first new immunotherapy approval in early stage lung cancer for those tumors with stage 2 to 3A expression of PD-L1 on 1% or greater. And as with the neoadjuvant setting, there are several adjuvant immunotherapy trials where we await results. And the ANVIL trial is the only one that actually has a primary endpoint of overall survival. All of them included both PD-L1 and positive and negative tumors. And these studies should start to report out relatively soon. All of them have completed accrual at least 2 years ago at this point. So what are my thoughts on immunotherapy for early stage lung cancer at the moment? I think it's great we're seeing positive results after many years of just having chemotherapy with modest benefits for patients. I think the neoadjuvant setting is interesting, particularly for those patients perhaps with lower PD-L1 expression or PD-L1 negative tumors, and also those patients with stage 2B and 3A tumors. In the adjuvant setting, I think there are situations where, for example, with earlier stage 2 tumors and stage 1B tumors, the adjuvant setting might be preferable. And also for those patients with high PD-L1. And I think one of the big changes in this year is we're going to need to be checking PD-L1 in all patients with early stage lung cancer. So I think we'll move on to the next section where we're going to have some cases and practical discussion.
Thank you very much, Patrick. Okay, so why don't we go into some cases and practical discussion now. And so the first case to consider is a 45-year-old male who presents with a melanoma in the arm, measured 1.5 millimeters in depth. Clark's level 4 had 1 mitosis and no ulceration, had no significant past medical history, exam was normal, underwent a wide excision and sentinel lymph node mapping and biopsy, and had a positive sentinel node. Notably was BRAF wild type. All systemic imaging was normal, and this patient was categorized as a stage 3A with a T2A N1A tumor. And so the question is, what would you do for a patient like this? So there's a couple of options. Surveillance is certainly an option. Adjuvant BRAF MEK or adjuvant anti-PD-1. And if you think back to this case, he was BRAF wild type, so adjuvant BRAF and MEK inhibition is not an option for him. However, surveillance or treatment with adjuvant anti-PD-1, both are viable options. And really, I think it's a personalized approach for each of these patients. This is a young patient who has good performance status, relatively small focus, but still, could potentially derive some benefit. And so I think in this patient, I personally would consider adjuvant anti-PD-1, although certainly surveillance would be on the table. Now let's contrast that with the next case. So this is a 67-year-old male. So we're going to talk about an older patient with other issues or other comorbidities. So 67-year-old male comes in with a 3 millimeter melanoma of the back. It has no ulceration, but does have a history of ileitis. The biopsy was not definitive for Crohn's, but has required transfusions for anemia. Exam was totally normal. This patient was taken to the operating room, underwent a wide excision and a sentinel node, had positive sentinel lymph node with multiple small deposits within that lymph node. Systemic imaging was normal, and this patient was a stage 3B, a T3A N1A. And so what are the options for this patient? And I think this is another story here. I think certainly surveillance is an option. Adjuvant BRAF and MEK inhibitors is actually quite a viable option in this patient if they're shown to be BRAF, if they have a BRAF mutation. And then adjuvant anti-PD-1 could certainly be given, I think, in the setting of of the ileitis, there could be some issues with regard to potential immune-related adverse events. However, there are studies suggesting that these agents can be used in patients with autoimmune disease. Now let's go on to the final case. So this is a 50-year-old female who presented with a melanoma on her lower extremity. She had a 6-millimeter melanoma with no ulceration, but Clark's level 5 with 5 mitoses. No significant past medical history. Exam was normal. Actually underwent imaging preoperatively and was found to have disease in the groin with no distant disease, and biopsy showed a BRAF mutant melanoma. And so I think the considerations with a patient like this would be, do you do either upfront surgery and with adjuvant therapy, either checkpoint blockade or with BRAF and MEK inhibition, or do you do neoadjuvant therapy followed by surgery, followed by adjuvant therapy? And I think there's a couple considerations here. You know, certainly with a patient who has, this is not hugely bulky, but she definitely has clinically apparent disease. I think considering neoadjuvant treatment would certainly be very, very tractable. And what we've seen is that using that neoadjuvant CTLA-4 blockade along with PD-1 blockade with the flip dosing regimen or IPI-1 Nivo3 has been quite effective in not only having less viable tumor at time of surgery, but also better outcomes overall with reduction in relapse-free survival. Neoadjuvant BRAF MEK can also be used. And honestly, I think a neoadjuvant approach with potential for adjuvant therapy would be favored in a patient like this. Of course, clinical trials are always the best option, but surgery followed by adjuvant therapy, approved adjuvant therapy in this patient would also be quite tractable. And so with that, we'll move on to Ronan, who will discuss a case of esophageal cancer.
Thank you. Well, this is a classic presentation that all of us obviously have learned in medical school with esophageal cancer. It's that of dysphagia, patient feeling something impacted their esophagus. So this patient, 75-year-old man, presents with a 4-centimeter distal esophageal mass, was clinically staged as T3N1. And you can see the PET scan there, SUV 11.9. But you know, the standard of care up until this year, you can do two things. You could either do, depending on where you are in the world, some people just give chemo alone. But in the US, a lot of us have preferred chemo radiation, which helps with lymph node clearance, which helps with achieving an R0 resection. However, the dose of chemotherapy you give with radiation has always been, you know, a question mark. The cross regimen is actually low dose carboplatin and paclitaxel. People have been trying to increase the dose of chemo to get more of a systemic agent, systemic doses. But that's very well tolerated, especially in a gentleman who's in his mid-70s. So then the patient had a minimally invasive esophagectomy. But as I said, the majority of patients, probably in the US with adenocarcinoma, 75-80% of people do not have a PAT-CR. And we haven't had anything to be able to offer them in the adjuvant setting apart from just watching. But the natural history of esophageal cancer is it recurs in the vast majority. And that's why our overall survival in esophageal was almost like pancreatic. It was, you know, really poor, unfortunately. The question of HER2, is that a biomarker we can use to try to, you know, we know the audience will know that not just trastuzumab is approved in breast, but also in upper GI tumors. So we actually did a study, RTOG 1010, to look at giving neoadjuvant trastuzumab if you were HER2 positive. Didn't impact any, it didn't work, which is disappointing. So we don't really have any targeted agents we can give in early stage disease. So the question really up for discussion here is, you know, what's the best adjuvant treatment option? Really, there's only one at the minute, which is in a patient like that, unless they have any contraindications, it would be adjuvant nivolumab. As I mentioned, the risk of recurrence, I showed the Kaplan-Meier curves, 11-month disease-free survival in someone who's had trimodality therapy is really concerning. We haven't had prospective randomized phase 3 data to show us that. So that also indicates that these patients with a malignancy like an esophageal or GE junction cancer, we can't just watch and wait for them because their disease will recur in a short period of time. And then when's the optimal time to start this in someone who has to recover from an esophagectomy? That's a big question. In our study, we looked at less than 10 weeks versus greater than 10 weeks. But Jennifer, what I'll tell you is, that's a subgroup analysis. Study isn't really powered for that. You as a surgeon, what I say to patients is, if you've got a fit patient who has had, say, a minimally invasive esophagectomy, has recovered, has, really regained all their strength, and you, after 7 weeks, you want to start them, that's fine. But if you've got an elderly patient who is a bit frail, is continuing to lose weight, has to see the dietitian, can't get used to the new anatomy, please wait for more than 10 weeks, because the subgroup show it, you don't actually hurt the patient by waiting. We don't want to go 16 weeks because our study didn't allow us to go 16 weeks, but give them a little bit of time to recover and then they can start the adjuvant treatment. I think that would be the best option.
That's great. Thanks, Ronan. That's a great discussion. All right. Well, in the interest of time, we'll move on to the next case discussion.
So Amanda presents pretty typically for patients diagnosed with bladder cancer. She presents with hematuria. She has good renal function. A cystoscopy is performed and shows a bladder mass. Biopsy confirms muscle-invasive disease. Standard treatment for muscle-invasive bladder cancer in patients who are cisplatin eligible is cisplatin-based neoadjuvant chemotherapy, which she receives 4 cycles of gemcitabine and cisplatin, and she's taken to the operating room for a cystectomy, and her pathology reveals residual T3N1 disease. And so the question is, what are the options for her after surgery? So historically, we would observe patients with this pathology at the time of surgery because there have been no studies suggesting that alternative adjuvant approaches improved outcomes. There have been retrospective studies seeking to determine whether or not we could switch to different chemotherapy than what was administered in the neoadjuvant setting. In those retrospective studies are small and biased and have shown mixed results. The new generation of studies seeking to explore immune checkpoint blockade in the adjuvant setting have enrolled such patients, understanding that this is a high-risk situation in terms of the chance of recurrence. So Checkmate 274 demonstrated an improvement in disease-free survival in patients with residual T2 or higher disease after neoadjuvant chemotherapy. Amanda's pathology is consistent with this. Her clinical presentation is consistent with this. And so adjuvant nivolumab would now be standard in this situation.
Great. Thanks so much, Matt. All right, so let's move on to lung cancer. And so Patrick, if you can talk about the next case.
Thanks, Jennifer. So this is a 65-year-old man who has a 30-pack year history of smoking, and we're gradually seeing increasing in screening for lung cancer. I need a screening chest CT. Which you'll see on the right, so in the middle of your screen there with a mass in the right lower lobe. He then underwent a CT-guided biopsy of the mass, which showed a TTF1 positive lung adenocarcinoma, and staging was completed with a PET scan and an EBUS, and this showed a clinical stage 2 tumor, T2N1. So how would we manage this patient? Would we consider neoadjuvant therapy first, surgery first, or do we need more information? So the standard of care for potentially resectable lung cancer depends on the stage. So for stage 3A disease, neoadjuvant chemoradiation followed by resection can be considered, or neoadjuvant chemotherapy. And there was a study conducted across the NCCN institutions in the US, and about 50% of institutions do each of these for stage 3A. Some institutions also do definitive chemoradiation for potentially resectable 3A, and that's a controversial area in general. However, in this patient's case, he had stage 2 disease, so a clinical T2N1. And he was referred for a clinical trial and decided to enroll, so in this case, induction chemoimmunotherapy. For these cases in general, particularly stage 2 and 3A disease, I think it's recommended to discuss their cases with the multidisciplinary team, particularly as we're seeing more integration of new therapies for early stage disease. And this was the outcome. So you'll see the pre-treatment PET scan and CT on the left, some reduction in disease in the middle of the screen, more evident probably on the CT, and that's something we sometimes see on PET scans. Depending on the timing of the PET, you may or may not see a metabolic response. At the time of surgery, the tumor was clearly resected, and pathology showed a major pathological response, so 10% or less residual viable tumor. And this patient has continued post-operatively after receiving chemoimmunotherapy or trial. Focusing more on the adjuvant therapy setting. So this is a 55-year-old Asian man who has an extensive history of smoking, presented with hemoptysis, so symptomatic presentation as opposed to a screening presentation. The chest X-ray showed a right upper lobe mass. CT confirmed that mass to be almost 5 centimeters in diameter, with a single lymph node involved at the right hilum. So again, N1 disease here. Staging was negative otherwise, and went to surgery and had a right upper lobectomy. This is probably the more common scenario across the US, in that most patients who have clearly resectable disease go to surgery up front. We may have to change this paradigm over time depending on results from neoadjuvant studies, but at the moment this is a very common scenario. The tumor was a lung adenocarcinoma, highly PD-L1 positive at 70%, and negative for mutations. And again, it's important in particular we check EGFR for these patients, as osimertinib is approved in the adjuvant setting and would be preferred if there was an EGFR mutation present. Only one lymph node was positive, and the patient received 4 cycles of adjuvant cisplatin-based chemotherapy with only mild neuropathy as a toxicity. So would you offer this patient adjuvant atezolizumab? I think given the high PD-L1 of 70%, negative EGFR, and the clear benefit for atezolizumab, yes, is the answer here. This particular case was prior to the approval, which occurred very recently, and he enrolled in a trial of adjuvant IO, very little toxicity, tolerated therapy well, and is currently being observed.
Thank you, Patrick. So a few provocative questions with regard to this subject. I think one is, what's the role of biomarker testing to guide candidate selection for immunotherapies in early stage cancers? And this is certainly an evolving area. I can tell you updated information from our pooled analysis, which was published in Nature Medicine, showed that tumor mutational burden and also interferon signatures were predictive of response to neoadjuvant immune checkpoint blockade in resectable metastatic melanoma, but would love to hear thoughts from others. Certainly PD-L1, T-cell infiltration, other molecular drivers or alterations. Ronan, do you want to take a stab at this first?
I think those upper GI tumors are clearly not as immunologically hot as melanoma, lung, bladder, kidney. So I think we're going to see that across multiple solid tumors, that things will change. What I can tell you is it didn't look like tumor cell PD-L1 was a biomarker that was very useful in esophageal cancer.
Gotcha.
A combined positive score of PD-L1 may be more useful, but we need more interpretation, because we know that we get interferon release post radiation, and that's going to cause that to go up. So again, we just need a little bit more information around that. Tumor mutation burden seems to play a role in, we have a tumor agnostic approval in the second line setting for a checkpoint inhibitor in those patients that are TMB high. Whether it plays a role in the adjuvant space or the neoadjuvant space, we don't know yet. And that would be similar answer to T-cell infiltration. And we've no driver mutations information at the moment that seems to be indicating in these early stage tumors whether a patient is likely to respond or not. So I think we're just at the very start of this. The Checkmate 577 esophageal study was the first study in this space for esophageal and GE junction. So as I said, we'll see a lot of other studies now in the next couple of years. Hopefully we'll get more answers.
Gotcha. Well, let's move to Patrick, because there's a lot more data with lung cancer. Patrick, what are your thoughts here?
Yeah, I think, so what we've learned really in the last 2 years is that there are two tests we need to do in early stage lung cancers. That's EGFR mutation testing and PD-L1. PD-L1 has probably more of an implication in lung cancer than in nearly every other malignancy, in that it guides our first line metastatic treatment. And it's looking like it may be important in early stage disease as well, in that particularly in the Empire 010 study, the benefit that was largely in the high PD-L1 tumors, perhaps some benefit in 1 to 49, but mainly in 50% or greater. The stepwise change in terms of PD-L1 was less evident for the PCR endpoint of CheckMate 816, and that there appeared to be benefit, at least in terms of PCR, for PD-L1 negative cancers, and we'll see how that plays out with event-free survival. The main TMB data we have in lung cancer is from the neoadjuvant setting with the CheckMate 816, which didn't appear to show a difference in terms of PCR, and again, we'll await the event-free survival. But again, to reiterate, I think the two things we as a community in lung cancer really need to be doing is for non-squamous tumors, testing for EGFR, because those patients are likely to derive benefit from EGFR tyrosine kinase inhibitors and probably don't derive benefit from immunotherapy. And on the other hand, for those patients who are not mutated, checking PD-L1 is a central thing now, especially for stage 2 and 3A tumors in the 8th edition.
Great. Okay. Matt, anything to add with GU?
Just in the interest of time, I would make one comment, which is that I think we have a double biomarker problem in the perioperative setting. Not only don't we know who benefits from treatment, we actually don't know who needs treatment. And sometimes these biomarkers are conflated, but they're actually two separate things. And I think we have to advance maybe who needs treatment first and then determine who benefits from treatment.
Great. And I think we can use the same slide to kind of talk about hot versus cold tumors and how can we actually enhance responses to neoadjuvant and adjuvant checkpoint blockade. I think, and Ronan, you had brought up, can we actually use strategies to increase PD-L1, favorable, PD-L1 within the tumor microenvironment? Can we radiate tumors, and make them more responsive to immunotherapy? Can we drive in T-cell infiltrate by injectables, and other strategies? Driver mutations, can we target oncogenic mutations and make tumors more immunogenic like we do in melanoma? Would love, general thoughts from each of you on that.
As we add more IO combinations in early stage disease, especially in the neoadjuvant space, we need to make sure we don't increase toxicity, which then impacts the ability of the surgeon to do what they need to do. And that's going to be the fine balance, especially when you combine radiation with a dual IO strategy. Now you're causing significant alterations, because we've seen this in some of our studies that we know radiation causes interferon gamma release. It causes a lot of checkpoints to go up, whether that's artificial, that's just part of the, the interferon gamma release. But now you're adding IO strategies. I think single agent PD-1 looks like it's well tolerated. I think I've seen it across the board. I think we can do that. Can we add in more things before surgery? That'll be the question. Or are we going to see more pneumonitis, more pericarditis, more of these things that we don't want to see? So that'll be interesting over the next couple of years as we try to tease that out.
Definitely. Matt, any thoughts on?
I certainly agree with those comments, and I would say that moving these drugs into the perioperative setting is a little bit of a double-edged sword, because it really creates some complexities in developing immune checkpoint blockade-based combination strategies, because that space to test those strategies in advanced disease has disappeared, and yet there is trepidation about moving combinations into a curable patient population. At the same time, the benefits, of course, are using this as a platform for reverse translational research. And so small studies with combinations to really dissect the tumor microenvironment at high resolution and generate insights into what's driving resistance clearly are showing promise.
That's great. That's an outstanding point. Patrick, did you want to build on that?
Yeah, just briefly, I think one potential thing that levels the playing field for lung cancer is the addition of chemotherapy to immunotherapy. We've seen that in advanced lung cancer, in that it makes PD-L1 less of a player, which presumably is because of some impact on the immune microenvironment. The other thing we are seeing in some studies in lung cancer is these novel combinations being used in adaptive clinical trials, where we're looking at combinations moving relatively quickly from being studied in advanced disease into the early stage disease in the neoadjuvant setting, with some of the focus that Matt mentioned on looking at correlative endpoints primarily. But I think we have to do that safely and obviously make sure there isn't an impact on the surgical outcomes as well.
Right, and I think that's an important message for the audience is in the context of clinical trials, do these in the context of clinical trials, but innovative design, using correlatives, really learning from every patient is really key. And this brings us to our next point. Ronan brought up toxicity, and I think, certainly, yes, we've seen a lot of promise with this, but we've also seen, a lot of immune-related adverse events. This is kind of just the spectrum of different immune-related adverse events that you can see, and really, what are the concerns? I think, certainly we've all become better at recognizing these, and patients are being informed and are able to recognize these earlier, but really earlier detection and management of these IREs is key. And again, I think, Ronan, thank you for the call out, because it does bring up major concerns for surgeons, for everyone on the team, and for patients. But there are real implications for surgeons. We've tried to educate our surgical community to really understand toxicity related to immune checkpoint blockade and considerations for the surgeon. I can tell you we've had numerous patients who actually have adrenal insufficiency and adrenal crisis, in the postoperative period, and you need to have that in your mind when you're treating these patients, because you might otherwise not really be cognizant of that. And so we have a publication that we put out just to inform the surgical community. And so what I'd really like to highlight through this is that there are multiple take-home messages here for surgeons, for medical oncologists, for other disciplines, not only independently, but I think together as multidisciplinary teams, we can learn a lot from this discussion. I think, certainly we've thought of a lot of different ones in the context of this. Ronan, did you want to bring up anything in particular?
Well, I think as we move these treatments now into the operative setting, quality of life becomes important as well, really important, because now you're asking people to embark on a long, arduous journey, which is obviously neoadjuvant space, then surgery, and then a year of a checkpoint inhibitor. So what I can tell you is in our study, Checkmate 577, we did a lot of quality of life, and thankfully it was really well tolerated, the adjuvant checkpoint inhibitor. But people were aware, you're asking me now to stay on treatment. But historically, when I had my surgery, I was done, and so that's going to be something we're going to have to get used to, talking to our patients, to try not to think of the whole journey in one big overwhelming moment, to try to compartmentalize it, and that we'll get patients through those different steps. But if they think about it as a huge, big, long, year and a half almost of treatment or whatever, it may be overwhelming for some patients.
Yeah, and I think talking to each other across disciplines is really important too. I'll bring up that Prado trial where we actually resect that index lesion, and if they've had a complete response, they're done, right? They don't need to go on to any adjuvant therapy. And granted, it's a clinical trial, but nonetheless, can we use these types of approaches across different cancer types using the neoadjuvant and adjuvant immune checkpoint blockade, and really learn from one another to help drive the field forward? Matt, any additional insights?
I was going to make a similar point, Jennifer, in that while pathological complete response is an intermediate endpoint or a surrogate endpoint, it might be an important tool for drug development. It might be an important tool for individualized decision making as we move forward and change treatment paradigms as well. So can we actually not only achieve these good outcomes, but also modify the treatment burden that patients were previously exposed to, and make this an ultimate win-win.
Great. And Patrick?
Yeah, I think very briefly, just to mention circulating tumor DNA, I think we're starting to see, there was a little bit of data there from Checkmate 816 and I think from Matt, from studies in bladder as well, but we're starting to see, so at least the first phase 3 trial in lung cancer, which uses post-operative detection of ctDNA to triage patients to either a year of therapy or no therapy. And I think that's potentially the way to go across many tumor types, especially those which secrete or sheds a significant amounts of circulating tumor DNA, and that it might also address many of the other issues we've brought up in terms of toxicity and in terms of impact on quality of life, if we can really select out those patients who need therapy. Great.
Well, I think it's been a great discussion. I think we still have a bit to learn, but the future is bright. And I think this ends our discussion today, which focused on the rapid progress being made with transitioning immunotherapies into early stage curative intent setting in many different cancer types. I hope you found the information and insights shared by our multidisciplinary faculty interesting and useful to your practice. And a big thank you to all of our excellent panelists. It's been a great discussion. I'm glad we've had a chance to learn from one another and to convey our experiences to our audience. We're only at the beginning of this exciting era, and I can look forward to many more practice-changing developments that'll hopefully improve outcomes for our patients with early stage cancers. And so thank you very much for your attention and for your expertise.
This activity is certified by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/DVD 860. This activity is supported through an educational grant from Bristol Myers Squibb.